Great. And then we're live now, so people will slowly come into the room. And what I'm interested in hearing a little bit about is where you are at this moment and what city you're in and what you've been doing this last week, as well as kind of what you're planning on doing next week.
Okay. So, first, my name is Hagit Berdishevsky, and I am I'm a physical therapist, more specializing in a Schroth method to treat patients with scoliosis and different spinal conditions. Now I am in New York City, actually in my little clinic studio here. And I finished the teaching of practical course 1 for physical therapists, how to treat people with scoliosis and spinal conditions. And tomorrow, starting the practical part 2 for advanced knowledge. And
Excellent.
thank you for hosting me.
Of course, of course. So I'll do a little bit of an introduction now that we have some more people in the room. So this is Dr. Hagit Berdishevsky, and well, first, to me, she is someone that I've been learning from and have the honor and privilege to learn from. She teaches a Pilates and Schroth class that I try to take as often as possible. In addition to just that, that's just my little perspective. Hagit is a Schroth therapist. She's studied and learned both from the German approach and from the Barcelona approach. And she teaches other Schroth therapists how to become Schroth therapists. And you are also a McKenzie therapist as well. The co-founder of the Scoliosis and Spine Online Learning Center, which is a fabulous resource, and also the chair of the SSOL Education Committee. Is that correct?
Correct.
Okay. And then you also have 2 clinics for Schroth therapy, one in New York and one in Israel.
Correct.
And you're also a Polestar Pilates educator. Is that correct?
Correct.
What else did I miss?
An instructor, not an educator, an instructor.
Okay. What else did I miss?
And I am a wife to David Berlin and a mother to Gali Berlin, who are now in Israel because I came here to the state to teach.
Great. And those are probably some of the most important, right?
Sure.
Yeah. Okay, great. So let's go ahead and kind of dive into the material. Does that sound good to you?
Of course.
Okay, great. So we want to hear kind of your story and where this amazing background and path started for you.
Thank you. So I started to work at the Hospital for Special Surgery in New York City with an amazing surgeon who you can see on the top left. His name is Dr. Buachi. He was the chief of the scoliosis services at the Hospital for Special Surgery. And he was also the vice president of the Scoliosis Research Society, which is the society for all the research going on spinal conditions. And luckily, he was working at HSS. He is originally from Ghana. And I want to say, I feel like I always have to say it, I'm lucky that I met him and I joined his voluntary non-profit organization named Focus for complex spine disorders treatment. And I went with him to Ghana, Africa, to treat patients post-operatively. And I was there for about 4 times in a duration of about 4 years. And each time the surgeons are operating on these children that you can see now with complex spine deformity that otherwise they have some impairments in the community and with their own body. So they definitely needed this surgery. And helping these children right after the surgery to recuperate and recover and be fast on their feet and walking and functioning as children, you know, having fun and going to enjoy life and go back to their families and even help as needed. And that really what initiate my connection to the world of scoliosis, to spinal condition, to understand the spine a little bit deeper as a physical therapist, and be really connected more to spinal conditions. From there, I decided to go ahead and studied the conservative method to treat scoliosis. Also to say that Dr. Buachi always said to me, Hagit, out of 10 people that come to my office to evaluate if they need spinal fusion, I want to operate on one. And the other 9, I will be really pleased, really happy if they could be treated conservatively. And with the right indication, whoever needs a spinal fusion, this is my job, he said. So I took it upon myself to, I realized, and I received from him the yellow book, the book of Katerina und Krista Schroth, and I looked at it and I decided, wow, this is an amazing, complicated, interesting method that I want to explore. And I went and I studied the Schroth method in Germany first, in the original Katerina Schroth clinic. I met with Krista Schroth. I came back to New York. I work with back at the hospital, trying to build up a Schroth clinic and getting patients before operation, after operation, and helping them to recuperate, recover life. And from there on, you can see in the next slide, basically, these are the people that I, again, really feel lucky and honored that I had in my journey up to date, a journey that took me about 15 years to work with the top, I feel the top in the field of scoliosis and spinal conditions. You can see that Krista Schroth, who documented and treated and built up the clinic of Schroth into the way it is now. You can see Dr. Lenke, who is also was the president of the Scoliosis Research Society, a top surgeon in the world for spinal conditions, who works now at in associate or works for Columbia University Medical Center. You can see Dr. Michael Vitali, who also worked for Columbia Medical Center, I think the chief of the services for children, and Dr. Manuel Rigaud, who I learned really what I know perfect, I hope, no, I don't know perfect, but I know that there is from him, I learned a perfect way to help people with spinal conditions.
Excellent. So let us talk a little bit more about what is the Schroth method. I think that's a great question. And then maybe we'll get a little bit into whether it can be helpful specifically for people that have spinal fusions.
Sure. The Schroth method is a conservative method to treat patients with spinal conditions. More specifically, it's scoliosis and sagittal plane conditions like hyperkyphosis or flat back or others way back. And it was developed in Germany back in the days by Katerina Schroth, who is a woman who had herself a scoliosis. and then further developed and become written even in the book of the Schroth method. And it's a method to use certain principles of correction to self-empower the patient. As I said, pre-operative, post-operative, in terms of, if it's pre-operative, try to reshape the torso and to halt progression or correct the scoliotic posture, which is the first goal. And post-operatively, it's going to be something that we're going to discuss next. And
Great.
here you can see in this picture some of the exercises, black and white, back in the days, outdoors. She believed a lot in the vitality and the fresh air, and also indoors with the wall bars.
Yeah. I love the part about the vitality in the outdoors, because now, you know, there's research that shows spending time outside in nature, it lowers and decreases our stress. And so she was really like ahead of her time.
Right.
Yeah, I think it's just amazing. Okay, so let's talk about specifically, we kind of talked about the improvement in the trunk shape, correct? Do you want to say a little bit more about this piece, or should we talk about spinal fusions and how it might be helpful for spinal fusions?
Sure, I can just say in one word
Yes,
that
absolutely.
what we're doing, what we're helping patients pre-operatively or non-operatively, and of course post-operatively, is about the posture, reshaping or correcting or aligning the posture with the knowledge from back from Ian Stock and Bowell that posted an amazing paper that it's free. It's on the Scoliosis Journal, free access online, about this cycle that spinal curvature and asymmetric loading, that also related later for post-operative. If there is asymmetric loading and malalignment in posture, that continues when you don't have a fusion, and asymmetric growth and vertebral wedging and a cycle of curvature. But it's also true, you will see later, when we have fusion, we need to still be conscious and aware about our posture.
Absolutely. So specifically, let's talk a little bit about how Schroth can be applied to people with spinal fusions.
So I think it's a very important point, because maybe you experience yourself, Jen, and other people, if they had fusion and they are the audience here. At times, surgeon correct the scoliosis, correct it by rods and even advanced methods, different methods. And not every surgeon, unfortunately, direct the patient to do something after the surgery, to strengthen the body, to balance the body, to look at the resultant posture after the surgery. And we see that post-operatively, at times there is need, because also to think about it, patient lived with a scoliotic posture before the surgery, and it is embedded in their brain about, and there are studies, MRI studies, that show that certain parts of the body are more collapsed and less active. So it's they're less active, and they represent a little bit different. And if you go for the operation, yes, you get a straighter spine for sure, and there is no, hopefully, progression of the scoliosis. But there are resultant areas in the body that are still needed to be taken care of. For example, you can see in this picture on the left side, the woman who have some frontal plane, or she stand with some shift or a tilt of the trunk. And this is right after the operation. And we need, because maybe she was like that before the operation, And with physical therapy, specifically, I believe in the Schroth method because we have the knowledge of how to align and what principles to use. And we have the knowledge about fusion. So respecting the precautions of the fusion. And I think your presentation went off for some reason. Good. So they need to work on alignment of the trunk in relationship to the pelvis. They need to open, if you look on the right side, this girl after the operation, her rib cage on the left side of the fusion, the ribs are still look like, if you look at my fingers, they still a little bit closed because that's the way it was in the concavity before. And we need to expand the ribs and increase blood flow and air and vitality to the lungs and align the body and gain muscle and improve respiration and the balance and the stability. And if there is some discomfort, there is a lot that we can do. And if you go to the next slide, and the next slide is just some pictures to show how am I using the Schroth specific exercises in always a symmetrical way to facilitate muscle activation in the direction of the correction with the knowledge of what posture the patient had before the surgery, which is important. Schroth therapists always look what was the spine before in respect to the fusion, now working on what is left for us, what is still need improvement, as I said before. And then you can go down a little bit more, and you can see also here, I put Jen from some exercises that we're doing together. And in this exercise, there is also alignment, and there is shoulder activation, and maybe lengthening, but with stabilization. And you can go a little bit more, and you will see that we're dealing also with a sagittal plane. Some fusions may need enhancement in the sagittal plane, because with time, as we age, the remaining, which you're going to ask me probably soon, the remaining parts that were not fused also need attention, and to make sure that nothing is changing after the fusion below or above the fusion.
And
so
I'll
we're
just
looking, yeah.
throw in there that semi-hanging is one of the things that I find extremely helpful. It's very active, and I can feel the expansion and the opening of any areas of collapse. So I'm a big fan of it. One of my favorites. Thank you.
Great.
Okay, great. So let's ask a little bit. I am curious because I know that I have students, and I know that there's people probably watching who have a little bit of flat back syndrome. So can you talk about that a little bit? And, we'll start with Schroth and flat back, and maybe we can talk about fitness and sports and a flattened back as well.
Okay. So flat back syndrome is, let's take it in relation to scoliosis prior to surgery. In the research development of scoliosis, in the biomechanics that bring scoliosis to be scoliosis as we see it, and result with shifts of the body from side to side when we look at the back. Actually, before it even becomes scoliosis that is seen on X-ray and measured with a Cobb angle and something that we see like that, there is a process that the vertebrae become wedged, or become structurally longer in the front of the body, like the picture that you see on the left side and the illustration with the yellow shaped vertebra that represent the torso. So the vertebrae get stimuli from its neurological, its hormonal. It is part of the process that brings scoliosis to be scoliosis as we see in 3 dimensions. The vertebrae goes forward, the spine goes forward first with side to side also wedging of the vertebrae, and then it becomes torsioned, and we see the end result as a 3D scoliosis. So flat back is the beginning, brings on the torsion, and it is associated and correlates with scoliosis because of the structural deformation of the vertebra from the early, very beginning in the development. And also not just the vertebrae, also the disc are known to assume some wedging alignment. If you look on the right side of this slide, you see a patient, let's say, without scoliosis, and you look at the illustration, normally or physiologically, the thorax having more length in the back of the thorax than in the front, as giving us a normalization of what we call kyphosis. Kyphosis is not a bad word. It's just the terminology for normalization of the torso, the thoracic part.
Great. And what are your thoughts about Schroth and flatback syndrome? And how is it possible for Schroth to help with flatback syndrome?
So yes, it's flatback. It's a part of first. It's part of scoliosis, but it's also, I didn't touch it. It can also be without scoliosis. There are certain percentage of the population in a normal way developing a flat back, meaning that the thoracic that's supposed to be kyphosis is more flat, like the previous slide, and that the lumbar, let's say, that's supposed to be lordotic, is also becoming flat. It's there is certain amount of the population known by research by Dr. Roussali from French, who found normal people having flat back as a genetic or epigenetic development of the spine. You know, like you have green eyes or blue eyes, you have yellow hair or black hair, you can have a flat back, but the percentage is low, just so you know. And with the Schroth method, again, with the knowledge of the biomechanics and the etiology, we don't know exactly the etiology, but with the research on that, we know that we need to basically, for the lack of better words, take the spine and bring it back to normalize kyphosis, to normalize lordosis, which is the hollowing in the low back. And to normalize it, you work with your patients using breath, using expansion in the direction that you want. You want to get more kyphosis, more round back. Then you encourage the patient to breathe to the posterior, to the back aspect of the thoracic region, to maybe work on mobilization of the lumbar spine from being more flat towards normal lordatization or hollowing of the back. So you can use muscle activation and breathing and some assistive device to regain, to reshape the torso as well.
And do you ever find, for example, some people that have, as far as spinal fusions, older instrumentation that didn't quite match the natural sagittal curves in the spine, have a flat back syndrome? And is there, can Schroth or can activity fitness, what are your thoughts around flat back syndrome that may be caused a little bit by instrumentation?
Yeah, that's an interesting it's an interesting topic and very upcoming knowledge.
Right.
There are programs right now. I'll go first to that. There are programs right now that the Scoliosis Research Society and the European Spine program. There are programs that design better the construction of the spine during the fusion, giving the patients the normalization of the spine from basically it's a sagittal plane. It's from the side that we need to normalize the spine. So nowadays they calculate very well and they know based on the pelvis measurement, they know what to do. You're right. Back in the days, the fusion was a little bit more, I can say, like us in different areas, more primitives, and, things are evolved with time and research. And there was not much attention to that lateral, to the side plane normalization of the back. And we see patients with, as you said, let's say flat back after the fusion, 20, 30, 40 years after they were operated when they were young. And same thing, we will try to work from what is available. So we cannot change the fusion.
Exactly.
We cannot, right, we cannot pull the spine backwards. And even that during surgery is more difficult to correct the side plane and give normalization. It's easier to give lordosis than to give kyphosis. The surgeon always say that. So also with therapy, we won't be able to pull the spine, let's say, and get normal kyphosis. But with breath, with advancement of, you see right now, let's say me touching the patient in the thoracic area on the side of the patient, not on the spine I cannot move, but the rib cage. Can we, with time and diligence and compliance, can we expand the ribs more posteriorly? But at all, it will not change the spine. And that's something that we have to understand. We won't be able to normalize the spine after fusion, but we will work on what's surrounding it.
Right.
If, we can, but it's if it's a work, and here come the statement that there is always thing to improve, but it depends on the diligence and the compliance of the patient. Some we can improve better than others. Fused areas, more, as I said, we cannot change the fusion, normalization of the spine.
Right.
And yes, let's say I do it with Schroth. We work with Schroth, but you can translate it and do any fitness exercises that encourage what you want to encourage.
Yeah, breath in the back body when there's a flattened when the ribs and the thoracic spine are a little bit more in a flattened position. So, and how about, I think that this is an interesting question and something that comes up a lot. So I know adjacent segment disease, I'm really curious to hear a little bit more about that. It's such a broad category, but let's talk a little bit about adjacent segment disease and Schroth, and maybe later on we'll get a little bit more into the fitness aspect and choices.
Okay, so adjacent segment disease, or ASD, is in other words degenerative disc disease and all what is entitled around it. It's a resultant of a stress on level below or level above the spinal fusion. it's also a natural progression of degenerative disc disease for people without fusion. So I'm sure I'm 50 years old, and we have natural changes in our body to certain, different extent in different people. So we're looking at what are these changes, what can it bring? A little, it could be a little, it can be a little bit more. Disc bulging, disc herniation, like in the picture, osteophytes, which are some bone formation around it, some malalignment, maybe the nerve get compressed. Basically, it's vertebrae below, typically more below than above because of the weight of the body, the weight of the fused spine on the segments that are not fused. And if we don't do what physical therapy or exercises can provide you in terms of maybe trying to hold these adjacent segment disease, then there is compression. Really, in other words, it's more compression of vertebrae below from, I will put the word instability, but it's not instability. People have it and they are very strong and they can do a lot of things, but the terminology call it kind of an degenerative changes that is a collapse, basically, from movement, from load, maybe from load that these segments take if they are above or below the fusion, and they move more, so obviously they will be more in friction and will create this. The symptoms are there's something that people are aware of. The symptoms of some numbness maybe, or discomfort, or nerve impingement. If you go to the next slide, some symptoms coming to the legs, or if the fusion is in the neck, then symptoms may come to the arms. They will improve. People usually feel better when, for example, they sit or they lie down, because then there is no weight on these segments that are not fused. There is no body weight, there's no load, and you feel more relief.
Okay, great. And how about treatment for
Good.
segment disease?
Exactly. So exactly enough with the symptom and what it is, because we can do things, definitely. So in the next slide, we'll start with Schroth and we'll come to fitness.
Great.
One a little bit about. So luckily, physical therapy and fitness, i.e. Pilates or yoga with caution, and fitness general, can help to reduce by preparing the body or working on strengthening and supporting, and basically the strengthening of the trunk musculature, let's say the core, the spine, the erector spinae, there's a spine that erect, the muscle that erect the spine, all the abdominal around it, but also global body strengthening can support and hopefully halt or reduce the progression of this adjacent segment disease. So looking at the patient and working with them, as you can see on the left side, maybe there is a little bit of a posture that put loads on that area. And when you work with the patient through Schroth, I always work on postural education, how to unload the segments that below or above the fusion, and strengthening the muscle around it. And from here, you basically go immediately in conjunction to fitness.
Right.
So yes.
So I'm going to repeat what you just said, because I think it's so important. You focus on unloading the segment below and then strengthening that area. Did I say that correctly?
Correct.
Great. Awesome. So let's just talk about generally what are the most important things for people with spinal fusions to consider when they're choosing a type of fitness or sport or activity? What are your thoughts on that?
Oh, there was as I said, yes, as I actually inserted here, there is not really one. I couldn't say one important thing.
No, of course
So
not.
yeah,
It's complex. It's complex.
it's complex. So first and always is to let the pain guide you. If there is a discomfort, you listen to your body, and that will lead you to the exercise. If something doesn't feel good, the movement doesn't feel good to you, you need to inform your instructor and yourself. You want to consider, do you have this adjacent segments disease? Do you know that you have? It's also like spinal stenosis, if people know, familiar with this term. Do you have it? So what kind of exercise you should do? You want to maintain stability versus mobility, because after fusion, as we said, the most riskiest areas are these that develop the adjacent segment disease. These are the areas below and above the fusion, and the fusion itself need stabilization. Mobility can actually increase some shearing between the vertebrae, and again, maybe impingement on the nerve. So you need to think about basically lengthening the body, expanding the distance between the rib cage and your pelvis, this area of the spine that don't have rib cage around it, and it's relying only on musculature, the core around, the core musculature, abdominal, oblique, external, internal, transversal, lower abdomen, as people know it, all the spine all the muscles in the back, stability. So you want to know, I as an instructor, I want to know also, what did you do before you choose any type of fitness? What did you really do before? Because if you tell me, I never ran, I never did this fitness, and now I want to start because I know that it can help me with symptoms. Before you jump into deciding what sport for you, you need to think, is this something that you love to do, you need to do, that bring you joy, that is not going to stress your spine? Choose something that provides you stability with joy, with fun, without pain, that is challenging, slowly challenge you, but is not too hard that you cannot perform it.
Yeah.
Consider all these factors.
Yeah, I love that. I mean, it's not a simple answer because it's multifactorial. There's lots of different considerations. So thank you for bringing that complexity and those considerations into it.
Right. And then in the coming slides, you can see the next slide. It's really, I was very impressed when I saw, and I work with Jen, and Jen is a Polestar Pilates educator as well. And you can see, I love these pictures actually, because in these exercises, you listen and you maintain, and you're doing it with cautious, of course, maintaining spinal stability. People used to say maintaining neutral spine, but it's such a complex terminology. I would replace the neutral spine with stability.
Great.
Because you can do different movement, just be stable.
Right. That's great. I do use the word neutral spine a lot, so I like that idea of spinal stability.
Right.
Cool.
And then you can continue and see that less recommended, maybe if you do have fusion, and if you know that you have adjusted segment disorder, and you know what, even if you don't have, as a precaution, Because when we are, for example, at this moment talking about adult, but soon we will come to adolescent, the next slide in a moment. But for now, regarding adults, we all, not just people with spinal fusion, I, myself, my husband, people I know around, if you ask people, do you get a pain discomfort in a classroom? Everyone will raise their hand to get some here and there. As we age, it's something to mentally and emotionally accept. Like we accept that the hair get gray. Hopefully we accept it, that we get some wrinkles. And to accept that part of aging is the spine. You know, the spine carries us for 50, 60, 70 years. There is a decrease a little bit in height. There is some degeneration, but we should not let it affect us. I mean, as much as we can, and do something about to slow it down, to age gracefully and strongly. Regarding fusion, respect what we said until now, and maybe do less of this picture exercise or sport that you see here that involve a lot of twisting and side bending and rotation that can increase, I'm saying can increase the risk, especially when someone is not a competent mover and don't have a history of exercising, and when entering a general classroom without attention to themselves, this is a little bit more a riskiest position.
Yeah, I liked what you said about, that came up yesterday. I was saying that as we age, things change. And it was hard for me to articulate how things change, but I know that I'm more drawn to stability as I've gotten older. And I think some of that and it goes back to listening to your body. And, as you said, pain is your guru. Really listening and being curious and knowing, like, this is what my body is telling me right now. And it's not what it told me 10 years ago. And that's totally okay. I think it's about looking at all the things that you can do, even though some doors shut. It just allows time and space for other types of activities.
Wow, you gave me the chill, Jen.
Thanks.
It's hot in here, but you gave me the chill because what you said is on the spot.
Yeah.
Right. And here come a lot of also a mental and emotional, a stable state of acceptance where we are in time, continue to thrive, to do our best and strengthen our body. And there's a lot of things that we can do. You can climb the average, you can rock climbing, but prepare your body slowly and do exactly as you said.
Yeah, great. Okay.
So in the next slide, just to say a little bit about adolescent, because I think it's important to distinguish, as you just said, with adolescent, originally the limitation are like my limitation, what I will tell my patient will be different than what I will tell my adult patient come to me. So adolescent, we want them after the fusion to live, almost to live life as normal, and they return to it. You can see here all of these patients in this picture have spinal fusion. The swimmer returned to swim after 3 weeks. This is a Dr. Lenke patient, and she won a national championship. The girls that doing ballet and cheerleading, and the runner who also won some national competition, and the ballet dancer, they can go back. What can we do? They are young, they are stronger yet, but it's very important to teach also the adolescent about stability with or after the activity. So yes, you do what you want to do as an adolescent. You still don't have the degeneration and the changes, but prepare, because we know from research not regarding patients with scoliosis or fusion, that hypermobile patients, those who go to be rhythmic gymnastic or ballerinas, they later come to physical therapy because they are lax, because they're hypermobile. They need to stabilize these joints. So if you had a fusion and it's really disregard the fusion, just general, if your sports and activity is mobility demanding, make sure to do some stabilization.
Yeah, and I would say when I had surgery when I was 12, and I was just I didn't have any limitations other than gymnastics. The surgeon said, yeah, no gymnastics. And I think that's really like the only thing that I wish I would have known is a little bit more about stabilization and exactly what you just said. Maybe after your activity, you spend some time stabilizing. I've heard you say this in other ways as well, kind of reprogramming the brain and coming back into symmetry. That would have been some of the information that I would have liked as a young person. So I'm just going to repeat that.
Right. Yes, no, it's a very good because it's your self experience.
Yeah. So.
Right. And it's, again, I will say it's not just after fusion. I tell this to my New York City ballet ballerina who have scoliosis, and she goes and do 5 hours of all kind of, you name it, what mobility she does. She needs to go back and do 30 minutes, 40 minutes with me, let's say, with what I give her is a Schroth exercise for stabilization, but she needs to go home and stabilize the joint.
Yeah. Great.
And the next slide gives a little bit of the Colombia that I'm associated with, guidelines for children, but they return to all kind of sport. Some sports sooner than other when they're comfortable, but they can return to all kind of sport with some precaution on the next slide, which is, let's say, collision sport. Maybe a little bit less recommended because of the risk of fracture.
Right.
Yeah.
That makes a lot of sense. Great.
That's your next question. Yeah.
Yeah. So my next question is about for people who have either gotten their first spinal surgery later in life or they've experienced a revision surgery. Are there different considerations when they're choosing fitness and sports? What are your thoughts about that?
Yeah, you know what? When you first of all, you have excellent questions.
Thank you.
I am thankful to you because you brought me to think and collect and right. So really, I don't see difference in what they need to do. Basically, it again comes to why did you need to have a revision? You needed to have a revision because an area become less stable. Less stable, again, what does it mean? It's not falling apart, but maybe below or above another scoliosis or another curve started to come. Or maybe this degenerative changes or something below or above the fusion typically become an area that, okay, now maybe we need to go back and now fuse these areas because they progress. I just have to say, there's no lack of better words for that. The areas have progressed in their spinal condition, and that means they are less stable. So the surgeon go and stabilize it with the fusion. This is what they do. So then you go and you make sure, okay, if I didn't stabilize my body before that, I must. It's a call. It's a wake up call. And then you choose to make sure you stabilize your posture, you do total body stability. It's not just the core. I want to emphasize it's very well. I should have probably put here a quote from Dr. Stuart McGill, who is an expert from Canada on back disorders and work with weightlifters, and now he works actually with the fitness world of yoga and Pilates. And he always said, this is a mistake that people do. It was in the past. Yeah, it's not for me. It's not exist anymore. You don't strengthen the core. You strengthen the total body from your toe to your hair.
That's great. I love that.
Yes, and be mindful. Mindfulness meaning if there is a depression, if there is a sadness, if there is unbelief in my body because I had to go to another fusion, I don't know how, okay, because I'm not a psychologist, but work with somebody and get yourself stable in all of these mental, physical, emotional. It's really the biopsychosocial term that we're using lately.
And I'll just echo that because yesterday I spoke to 2 other Pilates teachers that have spinal fusions, and they both very candidly brought up working with the therapist and how they talked about their spinal fusion experience. And they talked about having a gratitude journal. We're just writing down 3 things every day. Like, it was really quite beautiful. So it really speaks to that mindfulness. And Emily Hale, who's out of London, she was the one who said, I really think we need to talk about the emotional impact. Let's have a question about that. So thank you for also echoing that, because I think it's really important, and it's something that, people navigate in different ways, but it's important to navigate.
Yes, definitely.
Yeah. So
it's a big impact. We know it. I see it every day, every moment.
Yeah, I'm sure you do.
Yeah.
Okay. And I'm very excited to hear about this. How about, many people who, at least my experience, and I would love to hear your experience, it seems as though students who are fused later in life or who have a revision surgery, many of them are fused down to the sacrum, so L5 to S1, and then also into the pelvis. Are there different considerations for those types of people who have those fusions?
Thank you. Yes, I thank you also, because I had to go immediately and find this patient that I work with and check the differences. And it's really a big topic. Absolutely. It's a big topic. Another day we can talk just about the type of fusion, but I'll try to summarize it. There is on the right side, top right, selective fusion. Selective
Which
fusion.
is me.
Sorry?
That's me. I'm just throwing it out there for our audience. That's what I have, a selective fusion.
Oh, great. So selective fusion is typically done when you are young, when even if you can see this girl have also lumbar curvature, but the surgeon know from assessment, radiological assessment, and specific measurement that the primary curve is the thoracic. They will fuse the thoracic and the lumbar will get straightened because it's a compensatory, let's say. So they get that fusion. And now they need to stabilize the lumbar spine and stabilize, the neck cervical area. And they have all this, the whole core is more mobile. On one hand, it's more mobile, so more stability is required. On the other hand, it's great to have selective fusion because research documented that the lower you go with, I should have put here the reference to it and show, but the lower you go into the lumbar spine, there is documented more pain. okay, in the future, because you're fusing more, and then maybe two segments, L5, S1, maintain to carry the whole weight of the fused body. The weight, the movement is not dispersed between vertebrae. It's only on a small segment. So on one hand, it's good to have selective, because it's for the future, know to have less pain. But for that, you have to be strong. So keep it strong, not to get unstable. Then you have maybe the fusion to the lumbar, as you can see the second girl top left. And that, knowing that the lumbar was the major curve, you have to fuse to the lumbar. And again, the surgeon trying to save, always they try to save as many vertebrae in the lumbar as possible, because research, as I just said. So left maybe 2 or 3 vertebrae below, and for sure stabilization here is very crucial, because these 2 segments carry the whole weight of the trunk on their shoulders. And then we have the fusion to the sacrum, bottom left, common more with adult, and that will take me also to the fusion to the pelvis itself, the woman on the bottom right. And they need, this is typically with adults that already before the surgery have degeneration in this area, they have instability in this area, and not to risk that after the surgery they will continue to have a progression, you fuse them all the way down. So it's always the question, maybe it's better to fuse down, because now for sure you're not going to load any vertebrae, only 1 or 2 vertebrae, and now your pelvis is loaded, but there is less mobility in the lumbar spine. So there are pros and cons to each, but we know this. Today they're trying to, the pros of selective fusion and less to the pelvis, if you can, is preferred. If not, that's a great alternative for a really degenerative lumbar curvature, primary curvature in these patients. What are the different considerations? Now I will answer the question. The different consideration is the level of the fusion, of course, how much, and the available mobility. So the two young women on the top, they can move more also from the lumbar. They will move more, for here and for there. And maybe they actually need more stabilization exercise. Not that the bottom don't need, they need also, but they are kind of more safe. They already been fused there, but I still think, like the surgeon, that it's better to work hard to stabilize the lumbar and have less vertebrae fused, because at the end, fusion is a fusion. It's less
mobility.
Yeah.
Any other thoughts on fusions into the sacrum and the pelvis, and what you might suggest focusing on?
So, that's good. Any other consideration is this. Let's say we'll go to the next picture, P, actually, one below that. P, 67-year-old. Let's say that was fused. I think she was fused down below.
Mm-hmm.
And this one, or you can just scroll below. That she was not fused down to the pelvis. And we can see that with time, her pelvis is shifted away from where I put a little mark, a black dot at the neck, the center of the neck. And then I have a white line coming from the center of the pelvis that's supposed to touch the black dot in the center of the neck. And when you don't have a fusion to the sacrum or pelvis, then there is more chance that the pelvis can shift
Right.
again with the degenerative changes, with the instability. So those who are not fused to the sacrum and the pelvis needs to work immediately, in my opinion, after the fusion, to stabilize the pelvis or stabilize the trunk on top of the pelvis. Those who are stabilized to the pelvis, I think it's the next picture, Jay, 63 years old. I can work less on aligning the trunk over the pelvis because it is fused this way. So this person is now collapsing, assuming, and I believe, and assuming that at the operating room, when they've been operated, the doctors put them in good alignment, right side and left side and pelvis underneath. With time, you can see that his thoracic, let's say, is in the x-ray, is collapsing down. So the thorax go to the right in relationship to the lumbar and the pelvis that are fused together. So this patient needs to definitely work above the fusion, because we cannot touch the pelvis, we cannot touch the lumbar, we cannot align pelvis and lumbar, but we must lengthen the thoracic, open the concavity, which is on the left side of the patient, the concavity in the thoracic region, expand the ribs, work on rib cage expansion and muscle activation there, and alignment, because they can move their thorax. They are not fused there.
Right. And you said something really interesting. I've just never heard it verbalized or conceptualized it this way, but it's about working around the fusion. So, which is to me really interesting because that involves the ribs that we talked about before. And then if someone is fused into the sacrum and into the pelvis, it does involve the hips strengthening and keeping the hips mobile. And the same with like the shoulder girdle and the cervical spine. So that that's a great way of saying things.
I'm glad that you actually mentioned.
Fusion. Yeah.
Right. Because almost like bottom line is fusion straight to its best, the spine.
Yes.
The spine. Everything else is free to move.
Yeah, the soft tissue, the neuromuscular patterning, the ribs.
Very good.
The rest of the bones.
The scapula, the upper thoracic can gain an uneven shoulder. The shoulder blade can, they don't move. We are very well designed construct things. I don't want people to. Things don't shift and move freely in the body, but again, with aging, with less strength, you can, if you collapse to one side, then the shoulder blades and the shoulder girdle and one shoulder can protrude forward, and then you get arthritis and impingement and bursitis and shoulder pain. And then there is also in the sagittal plane, meaning from the side, the neck. If you don't take care of the opening of the chest, then the neck, you can see the lady, if you scroll down to be 28 years old. She's also young, though. She's young, even below this one. And in the picture on the left side, where there is an arrow in her body picture, her neck, because she's actually fused all the way to the T1, to beginning of her neck. And without stabilization of the neck, her neck will collapse forward. Forward head posture is so important to control.
Yes, and I completely agree with that. And I'd love to hear your thoughts about how you think about working with the head, neck, and shoulders with that forward head posture.
Fantastic. Forward neck posture. I don't know, do people can see me also live? I hope if they can see
Here,
me.
I'll change it for just 1 minute so that we can see
Great.
you bigger.
Right.
There you go.
Okay. So forward neck posture basically involves few things, but it does involve rounded shoulder, let's collapsed chest, many times just from activity of daily living, working on the computer, working on the cell phone, not being aware. And if you have fusion and these segments are not fused, they become the unstable. And the weight of the head is to forward. Our body weight wants to fall forward. And if we don't have enough strength here, the head typically don't go backwards. It is falling forward. We're looking forward. We're aiming forward. We're talking forward. And so how do we work on that? It's really simple. It's really simple. It's thinking about opening the chest in the front from side to side, like an accordion. Hopefully people know accordion. That was back in the days. And thinking about opening between the shoulder blades, side to side. Don't think about going backwards with the shoulder because it's not natural and you cannot really assume this position for a long time. But widen your trunk, widen. And then the neck musculature, lengthen the back of the neck. Not unnatural, because that is not natural, but lengthen like a mother cat. I always like this image. It's actually came from a patient of mine. A mother cat pulling her baby calf backwards while you're looking on the horizon. So this is on a daily basis, thinking about accordion or a smiley face in front and in the back, and looking on the horizon with a lengthening of the back. In terms of exercises, there are really endless of exercises that you can do in fitness, in Pilates, that involve the organization of the head, neck, and shoulders, even starting from being on all four and making sure that you don't drop the head.
I just taught that this morning.
Wow, fantastic. So it is like something like that, on hands and knees.
Mm-hmm.
Let me see myself. Okay. And you holding the neck. Hold it. Shoulder unshrug. Open the chest. You can go later to planks like that and hold. Don't let your neck drop. I like the on hands and knees, progressing into planks, each one with their own capability and the strength to do modified planks or something against gravity.
Yep.
And there are many exercises. Go to join Jen classes, and you will learn what to do.
So I think that we've covered a lot. Are there any other, I picked up on that, the head, neck, and shoulders, because I oftentimes in my intro classes will spend a whole class on, I call it, where the heck is my head?
Wow.
And I find it metaphorically interesting that we're a little bit disconnected. Are there when people are choosing like their fitness or what to focus on, are there any other areas of the body? I know we're talking whole body, but are there any other areas of focus that you recommend? I mean, you also did say stabilizing the spine. I
would say, yeah.
Go ahead.
Sorry. Wow. Of course, yeah. We always, screen from the bottom up. The feet.
Yep.
Lately, I'm more and more sensitive to collapsed feet.
Me too. I spend a whole class on working with the feet and the base because when people, if people are not fused into the sacrum and the pelvis, or if it's just scoliosis, I think the feet can really affect the pelvic shift. So tell us
and
more
the
about
hips.
the feet.
Yeah,
Yes.
right. So even as a general, listen, at the end, when you look in the mirror and you see and I'm fused to the pelvis, I'm not fused to the pelvis, I have only selective fusion. But look, I encourage looking at the mirror and seeing what I need to work on. Go to work with a therapist, of course, or with a instructor like you who very knowledgeable and know to look at the patient. Work with somebody, maybe that's the first, find someone who is knowledgeable, that will look at what's going on? Where are your feet? Are you flat-footed? Are your feet falling in? The big toe not touching the ground or touching too much? Do you have a sway? Do you have a posture where your pelvis is in front of you and your trunk go back, like sway back? And work on the pelvis. Yes, the pelvis and the pelvis and the spine is so crucial. For example, even with fusion not to the pelvis, I see a lot of patients who like this.
Yes.
The pelvis forward, because that areas with no fusion to the pelvis, we call it a sway back. So working on the pelvis, hip strengthening. If there is a pelvis that go to one side, there's going to be lengthening of the musculature here. There's going to be weight bearing on the side where away from the pelvis actually, and shortening here. So looking at the hip complex, okay, very important. Strengthening of the glutes forever. These are the most important muscles for function.
Great. Thank you for that. And I'm wondering, does anybody who's watching have any questions? If you do, go ahead and type them into the chat, and we'll just see if there's anything else that we haven't covered, or if someone has a specific question. But Hagit, thank you so much for your time.
Thank you, Jen.
Appreciate it. It's great to hear your thoughts specifically on spinal fusions, around fitness, around sports, Schroth, because you kind of do it all. Great.
Yes, yes. Love what I do. And wow, it's very nice that you're doing this service to the community, Jen.
Oh, thank you.
I appreciate.
Thank you. Great. So I don't know that we have any questions. Anything else you want to add at the end, Hagit?
Be happy, be strong, listen to music that you love. Yes, go out, hike.
I love that. Yep.
Yes.
Great. Okay. Well, thank you so much. And
you're welcome.
I will see you soon. Thank you.
Bye-bye.
Bye.